Okay, good afternoon, everyone. Welcome to the 98th CME Talk Series organizing by School of Medicine, Faculty of Medicine, Biosciences, Nursing, Masa University. Today we have two speakers for this event, Associate Professor Dr. Win Thu Newt and Associate Professor Dr. Myokita. So let me introduce to the first speaker of the day today, Associate Professor Dr. Win, and she is associate professor at Masa University in medicine department, and she completed MBBS at University of Medicine Mandalay, Myanmar, and MRCP from UK, Masters of Internal Medicine from University Malaya, Malaysia, and fellow in clinical hematology, Malaysian Society of Hematology and Malaysia. She's having around 18 years of experience, which includes 13 years of university hospital for clinical practice and 5 years of university for medical academic teaching. And she involved in the various teaching aspects, include internal medicine to the medical students and dental students, etc. And her research interest is apart from the internal medicine and hematology, she's also interested in medical education that reflects the publication of her recent publications. So apart from that, she is also involving in various professional organizations, which includes Malaysian Medical Association, etc. So without any further ado, I would like to introduce Dr. Associate Professor Dr. Wint to talk today. And floor is yours, Dr. Wint. Thank you.
Thank you, Dr. Suresh. I share the screen.
Yeah.
Oh, screen already shared, right?
Yes, yes.
Okay. So, good afternoon, everyone. Today, I would like to present presentation advances in lymphoma treatment. This is the outline of my presentation. What is lymphoma? Lymphoma is a hematologic neoplasm which arises from lymphoid tissue. Lymphoma is diagnosed from pathological findings on tissue biopsy. Lymphoma can be divided into two groups, Hodgkin lymphoma and non-Hodgkin lymphoma. Hodgkin lymphoma represents about 10% of all lymphomas. Non-Hodgkin lymphoma represents about 90% of all lymphomas. What is Hodgkin lymphoma? Hodgkin lymphomas are lymphoid neoplasms in which malignant cells are admixed with the heterogeneous population of non-malignant inflammatory cells. Classical Hodgkin lymphoma represents about 90% of Hodgkin lymphoma. And non-Hodgkin lymphoma. Non-Hodgkin lymphoma are malignant tumors of the lymphoid tissues which arise from the B cells, T cells, or NK cells. There are B lymphomas and T lymphomas. B lymphoma cells represents about 85% of lymphoma. T lymphoma represents about 15% of lymphoma. Aggressive non-Hodgkin lymphoma and indolent lymphoma. Diffuse large B cells lymphoma are the most common type of aggressive non-Hodgkin lymphoma, and DLBCL represents about 25% of non-Hodgkin lymphoma. Let's look at the epidemiology of lymphoma in Malaysia. Lymphoma is the fourth most common cancer in Malaysia. Of these patients with lymphoma, majority of the patients, about 60%, were detected at late stage 3 and stage 4. Hodgkin lymphoma has a bimodal age distribution, with a peak in young adults aged 20 to 39 and a second peak in older adults aged 65 and older. Non-Hodgkin lymphoma are more common in older adults aged 60 years and above. Lymphoma is more common in men. Classification of lymphoma. Classification of lymphoma is needed for evidence-based treatment decisions and assessing prognosis. In 2022, two distinct classification systems were published. International Consensus Classification World Health Organization 5th edition. As per WHO 5th edition, there are more than 60 subtypes of lymphoma. Here I mention a few names of B non-Hodgkin lymphoma which I will mention again in other slides. Diffuse large B-cell lymphoma, follicular lymphoma, mantle cell lymphoma, marginal zone lymphoma, chronic lymphocytic leukemia, small lymphocytic lymphoma. Clinical presentation. The clinical presentation varies with the type of lymphoma. The most common presentation is lymphadenopathy. Patient may present with B symptoms such as unexplained fever, night sweats, and weight loss. Other clinical presentation includes other symptoms like fatigue, symptoms related to extranodal disease, oncology emergency, and paraneoplastic syndrome. Diagnosis. Diagnosis of lymphoma can be made by history, physical examination, and investigations. Tissue biopsy is compulsory for confirmation of diagnosis of lymphoma. Images such as PET-CT scan is important for staging and response to treatment. Staging of lymphomas can be made by Lugano classification derived from Ann Arbor staging. Stage 1, Stage 2, Stage 3, and Stage 4. Treatment options of lymphoma. Treatment is tailored to the specific type of lymphoma. In low-grade lymphoma or indolent lymphoma, the lymphoma cells divide slowly and may be present for many months before diagnosis, and they typically behave in an indolent fashion. Asymptomatic patients with low-grade lymphoma may not require therapy and are managed by wash and wait. Indications for treatment include mild systemic symptoms, lymphadenopathy causing discomfort or discomfortment, bone marrow failure or compression syndromes, high-grade lymphoma or aggressive lymphoma. The lymphoma cells divide rapidly and are typically present for a matter of weeks before diagnosis and may be life-threatening with high risk of extranodal involvement. These patients need treatment at initial presentation. Treatment options include systemic therapy such as cytotoxic chemotherapy or immunochemotherapy or radiation therapy. Currently, this is the standard therapy for lymphoma. Standard of care for advanced stage classic Hodgkin lymphoma is ABVD plus or minus radiotherapy. Other options include immunotherapy, brentuximab plus AVD. The standard of care for treatment of newly diagnosed DLBCL is immunochemotherapy R-CHOP. Other options include polatuzumab plus RCHP. The standard of care treatment strategy for relapsed refractory advanced stage classic Hodgkin lymphoma is salvage therapy followed by high-dose chemotherapy plus autologous transplant. In relapsed refractory diffuse large B-cell lymphoma, the standard of care is salvage therapy followed by autologous transplant in chemosensitive disease in suitable patients. If the relapse is chemorefractory or progressive disease or relapse after transplant, then CAR T cell therapy is an option. This slide shows the historical timeline of advanced classic Hodgkin lymphoma discoveries and innovations. In 1980, AVPD chemotherapy became standard of care in advanced Hodgkin's lymphoma patients. In 2018, Echelon-1 study demonstrates the viability of brentuximab vedotin in combination with AVPD. Treatment of classic Hodgkin lymphoma. Treatment approaches involve defining patients as early stage disease or advanced stage disease. More than 75% of all adults newly diagnosed with Hodgkin lymphoma can be cured with standard chemotherapy, radiation therapy, or both. Response assessment can be performed by Lugano Response Criteria for Lymphoma 2014. Complete response refers to complete disappearance of all lesions of lymphoma in response to treatment. Partial response refers to more than or equal 50% reduction in measurable tumor lesions of lymphoma in response to treatment. Overall response rate refers to complete response plus partial response. Refractory disease is defined as the disease that did not achieve complete response with initial treatment. Relapse is defined as the disease that recurs after complete response. Progression-free survival is calculated as the time from randomization to relapse or disease progression or all-cause death or the date of the last follow-up used for censoring whichever came first. Let's see the treatment outcome in classic Hodgkin lymphoma. After initial treatment, more than 90% of an early stage classic Hodgkin lymphoma can achieve complete response. In advanced stage classic Hodgkin lymphoma, more than 80% can achieve complete response. 10 to 15% of the patients do not respond adequately to initial treatment or progress after an initial partial response, that is, refractory disease. Nearly 15% of patients will later relapse after achieving a complete response. Since the cure rate for classic Hodgkin lymphoma with initial treatment is high, researchers are now focusing on adjusting the standard treatment regimen to reduce the long-term side effects and improve quality of life for survivors. Researchers are also conducting clinical trials for novel therapies to treat the minority of patients with relapse or refractory disease. This slide shows the second line and subsequent therapy for treatment of classic Hodgkin lymphoma. The standard of care treatment strategy for relapse or refractory classic Hodgkin lymphoma is high dose chemotherapy followed by autologous stem cell transplantation if chemotherapy sensitive in suitable patients. Patient with relapsed disease that responds to salvage chemotherapy and ideally becomes FDG PET-CT negative should be considered for high-dose therapy plus autologous transplant. Maintenance therapy with PV following transplant can be considered for patients with high risk of relapse. Those with refractory disease might benefit from allogenic stem cell transplantation. Second-line therapy of classic Hodgkin lymphoma include brentuximab vedotin or nivolumab or pembrolizumab. What is brentuximab vedotin? Brentuximab vedotin is an anti-CD30 directed antibody drug conjugate. ADC consists of three components: CD30 specific chimeric IgG1 antibody, microtubule disrupting agent MMAE, protease cleavable dipeptide linker, which binds MMAE2 monoclonal antibody. The monoclonal antibody component of ADC binds to the cells which express CD30. ADC CD30 complex is internalized within the cell. MMAE is released. MMAE binds to the tubules and disrupts the cellular microtubular network, inducing the cell cycle arrest and apoptosis. This is the indications for brentuximab vedotin: anaplastic large cell lymphoma, Hodgkin lymphoma, mycosis fungoides, peripheral T-cell lymphoma. What is pembrolizumab? Pembrolizumab is an anti-PD-1 humanized monoclonal antibody. Tumor cells overexpress the cell surface protein PD-1. PD-1 on tumor cells binds to PD-1 on PDL. Tumor cells overexpress PDL1. PDL1 on tumor cells binds to PD-1 on T cells, leading to T cells exhaustion. This immune checkpoint is an important survival mechanism for tumor cells. Immune checkpoint inhibitors such as pembrolizumab and nivolumab can inhibit this checkpoint in the immune response and allow T cells killing of tumor cells. Pembrolizumab is an anti-PD-1 monoclonal antibody. Anti-PD-1 binds to PD-1 on T cells. This blocks the binding of PD-1 ligands from tumor cells, leading to T cells activation and killing the cancer cells. This is the indications for pembrolizumab: relapse or refractory classic Hodgkin lymphoma, relapse or refractory primary mediastinal large B-cell lymphoma. Let's move to treatment of DLBCL. In 1976, combined chemotherapy CHOP, that is cyclophosphamide, doxorubicin, vincristine, and prednisolone, was introduced for treatment of non-Hodgkin lymphoma. In 1997, that is after 25 years from introduction of CHOP chemotherapy, R-CHOP became the first targeted treatment for B-cell non-Hodgkin lymphoma. Rituximab in combination with chemotherapy was the first FDA-approved treatment to improve the survival for patients with CD20 positive non-Hodgkin lymphoma, including DLBCL. Since 2002 until now, that is for more than 2 decades, R-CHOP remains the standard of care for treatment of newly diagnosed DLBCL. What is rituximab? Rituximab is an anti-CD20 monoclonal antibody. CD20 antigens are present on the surface of B lymphocytes. CD20 regulates the cell cycle initiation and possibly functions as a calcium channel. Rituximab binds to CD20 antigens on the cell surface, activating complement-dependent B cell cytotoxicity, antibody-dependent cellular toxicity, antibody-dependent phagocytosis, and direct cell death. The use of rituximab include chronic lymphocytic leukemia, non-Hodgkin lymphoma, relapsed or refractory low-grade or follicular B-cells non-Hodgkin lymphoma, follicular B-cells non-Hodgkin lymphoma, non-progressive low-grade B-cells non-Hodgkin lymphoma, diffuse large B-cells lymphoma. Addition of rituximab to CHOP in previously untreated DLBCL improves progression survival and overall survival in the long term. More than 60% of patients may be cured with R-CHOP. Up to 40% will relapse after R-CHOP or are primary refractory to R-CHOP. In addition, DLBCL subtype retains prognostic value with R-CHOP therapy. DLBCL ABC subtype was associated with inferior outcome. Despite multiple attempts to improve on R-CHOP, R-CHOP remains the standard of care for treatment for newly diagnosed DLBCL. In Polaris study, polatuzumab vedotin was studied. Among patients with previously untreated intermediate risk or high risk DLBCL, the risk of disease progression, relapse, or death was lower among those who received pola RCHP than among those who received R-CHOP. Hence, the first line of therapy for treatment of DLBCL include R-CHOP as well as pola-R-CHP, that is polatuzumab vedotin plus rituximab plus cyclophosphamide, doxorubicin, and prednisolone. What is polatuzumab vedotin? It is CD79B directed antibody drug conjugate. CD79B is B cell specific cell surface protein commonly expressed in mature B cells lymphomas. ADC consists of three components: CD79B specific humanized IgG1 antibody, microtubule disrupting agent MMAE, and linker. The monoclonal antibody component of ADC binds to the CD79B. ADC79B complex is internalized within the cell. MMAE is released. MMAE binds to the tubules and disrupts the cellular microtubule network, inducing cell cycle arrest and apoptosis. The use of polatuzumab vedotin are as shown below: relapsed or refractory DLBCL and a previously untreated intermediate or high-risk DLBCL. Advances in treatment of lymphoma. Several immunotherapies have been shown as promising agents in treating different types of lymphoma. What is immunotherapy? Therapies that enlist and strengthen the power of a patient's immune system to attack tumors. Immunotherapy include monoclonal antibody. Monoclonal antibody includes monoclonal antibody drug conjugate, humanized Fc modified cytolytic CD19 derived monoclonal antibody. Targeted therapy such as immune checkpoint inhibitor, targeted therapy such as targeted small molecules, cellular immunotherapy like CAR T cells therapy, and bispecific antibodies. Monoclonal antibody, anti-CD20 monoclonal antibody like rituximab is used in CD20 positive non-Hodgkin lymphoma, DLBCL, follicular lymphoma, CLL, SLL treatment. Glyco-engineered type 2 anti-CD20 monoclonal antibody obinutuzumab is used in treatment of CLL or follicular lymphoma. CD30 directed antibody drug conjugate, brentuximab vedotin is used to treat Hodgkin lymphoma and T cells lymphoma. CD79B directed antibody drug conjugate, polatuzumab vedotin is used to treat DLBCL. CD19 directed antibody drug conjugate locastuzumab tesirine is used to treat relapsed refractory large B-cell lymphoma. Humanized Fc-modified cytolytic CD19 directed monoclonal antibody tafasitamab is used to treat relapsed refractory DLBCL in combination with medication called lenalidomide. Targeted therapy immune checkpoint inhibitor. Anti-PD-1 humanized monoclonal antibody pembrolizumab is used in relapsed refractory Hodgkin lymphoma treatment and relapsed refractory primary mediastinal B-cell lymphoma treatment. Anti-PD-1 fully human IgG4 monoclonal antibody nivolumab is used to treat relapsed refractory Hodgkin lymphoma. Targeted therapy, targeted small molecules, selective inhibitor of nuclear export, selinexor is used to treat relapsed refractory DLBCL. Bruton's tyrosine kinase BTK inhibitor. First-in-class drug ibrutinib is used to treat CLL, SLL, relapsed refractory MCL, relapsed refractory marginal zone lymphoma, and Waldenstrom macroglobulinemia. Second generation BTK inhibitor acalabrutinib is used to treat CLL, SLL, relapsed refractory mantle cell lymphoma. Second generation BTK inhibitor zanubrutinib is used to treat CLL, SLL, relapsed refractory mantle cell lymphoma, and relapsed refractory marginal zone lymphoma, and Waldenstrom macroglobulinemia. B-cell lymphoma 2 BCL2 inhibitor venetoclax is used to treat CLL, SLL. Cellular immunotherapy. CD19 directed chimeric antigen receptor CAR T cell therapy, such as Tisacel, Acicel, Lisocel, is approved for treatment of relapsed refractory large B-cell lymphoma. Rexulcel is used to treat relapsed refractory mantle cell lymphoma. Currently in developed, bispecific antibodies are in development for treatment of B-cell lymphoma. This diagram shows the timeline of recent advance in treatment of lymphoma. 2013, obinutuzumab, 2014, ibrutinib, 2017, pembrolizumab, 2018, CAR-T, Tisacel, 2018, brentuximab, and 2019, polatuzumab, 2019, venetoclax, 2019, acalabrutinib, 2020, CAR-T, 2020, tafasitamab, 2020, selinexor, 2021, local, 2021, sadubrutinib, 2022, CAR-T, and 2022, CAR-T, Yescarta. Let's see the treatment outcome in DLBCL. After initial treatment with R-CHOP, about 60% of patients may get complete response. However, 10% of patients do not respond adequately to initial treatment, that is, primary refractory disease. Nearly one-third of patients will later relapse after achieving complete response. This slide shows the second line therapy for DLBCL. For those with intention to proceed to transplant, second line therapy include salvage chemotherapy, CAR T cells therapy, and polatuzumab vedotin plus or minus rituximab plus or minus bendamustine. In PRIMA study, as compared with conventional chemotherapy, treatment with high-dose chemotherapy and autologous bone marrow transplantation increases event-free survival and overall survival in patients with chemotherapy-sensitive non-Hodgkin lymphoma in relapse. The standard of care treatment strategy for patients with relapsed or refractory large B-cell lymphoma is high-dose chemotherapy followed by autologous stem cell transplantation if chemotherapy sensitive in suitable patients. However, because of treatment intensity, this approach has only been feasible in half of the patients. Because of chemotherapy resistance, this approach has only been successful in a quarter of transplant-eligible patients. CD19 targeted CAR T cell therapy has dichotomized the management of relapsed refractory diffuse large B cell lymphoma. This is the algorithm for second-line therapy for large B-cell lymphoma. If the first relapse occurs in less than 12 months from first-line therapy, and if the patient is eligible for CAR T cells, the second-line CAR T cells therapy such as axi-cell or liso-cell can be given, and which can lead to projected cure in nearly 20% of all second-line large B-cell lymphoma. If the first relapse is more than 12 months from the first line therapy, and if patient is eligible for transplant, then second line salvage therapy is given, and if the lymphoma is chemosensitive and achieve at least partial response after salvage therapy, autologous stem cell transplantation is suggested. And cure can be in 5% of all large B-cell lymphoma who are treated with second-line therapy. What is chimeric antigen receptor T-cell therapy? CAR T-cell therapy is an cellular immunotherapy that reprograms a patient's T-cells to engage and eliminate malignant cells. It is living drug. What do you mean living drug? CAR T cells will continue to multiply in the patient's body, and with guidance from their engineered receptor, they will recognize and kill the cancer cells that harbor the target antigen on their surfaces. CAR T cell therapies targeting CD19 antigen have demonstrated high efficacy in clinical trials for patients with B cell malignancies. CAR T cell therapy include three processes. Number one, leukapheresis, collection of T cells from the patient. Number two, manufacture of CAR T cells in the lab. Number three, CAR T cells infusion back into the patient. This slide shows the FDA-approved CAR T cells therapy in B cells non-Hodgkin lymphoma. This are cells in B relapsed refractory B cells non-Hodgkin lymphoma, Yescarta in relapsed refractory follicular lymphoma, as well as relapsed refractory B cells non-Hodgkin lymphoma, Tacatus in relapsed refractory mantle cell lymphoma, Breyanzi in relapsed or refractory B cells non-Hodgkin lymphoma. This table shows the comparisons between acid cell, Texas cells, and Lixo cell. The complete response rate of CAR T cells therapy for relapsed refractory large B cells lymphoma who receive multiple lines of therapy is quite impressive. Complete response is about 40 to 60%. This diagram shows the second line therapy of the DLBCLs and third line therapy of the treatment of DLBCLs. This slide shows the FDA-approved novel agents in relapsed refractory DLBCL. Polatuzumab vedotin plus bendamustine plus rituximab is given as second-line therapy. Tafasitamab plus lenalidomide is given as second-line therapy. Rituximab tazarim is given as second-line third-line therapy, as well as it can be given in relapsed or refractory large B-cell lymphoma in adults after more than or equal to 2 lines. Selinexor is given as third-line therapy. All these drugs got the accelerated approval from FDA. What is tafasitamab? Tafasitamab is a humanized Fc-modified cytolytic CD19-derived monoclonal antibody. CD19 antigen is expressed on the surface of pre-B lymphocytes, mature B lymphocytes, and malignant B cells in diffuse large B cells lymphoma. Tafasitamab binds to CD19 and mediates B cell lysis through apoptosis dependent cellular cytotoxicity, antibody dependent cellular phagocytosis (ADCP). Administering tafasitamab in combination with lenalidomide results in increased antibody dependent cellular cytotoxicity activity compared to either agent alone. What is antibody drug conjugate? Let's make revision. The mechanism of ADC include 5 steps. The monoclonal antibody of ADC binds to the antigen on the target cell. The ADC antigen complex is internalized by endocytosis. ADC degrades in lysosome and cytotoxic payload drug is released. Then the action of the drug occurs in the cell, either microtubule disruption or DNA intercalation. So just now I already mentioned about the two ADC, polatuzumab vedotin and brentuximab vedotin. They both act through the microtubular disruption. Now I will introduce the new drug, tocilizumab tasirin. The mechanism is a little bit different, DNA intercalation. And then all these actions of drug leads to apoptosis of target cells. Let's move to locastuzumab testering. It is CD19-directed antibody drug conjugate. ADC consists of 3 components: a humanized IgG monoclonal antibody directed at CD19, cytotoxic alkylating agent, which is different from the previously I mentioned, and linker. The monoclonal antibody component of ADC binds to CD19. ADC CD19 complex is internalized within the cells. The drug is released via the proteolytic cleavage, and the drug then binds to the DNA minor groove and forms highly cytotoxic DNA interstrand crosslinks and induce cell death. So here, the drug is alkylating agent. Selinexor. What is selinexor? It is oral first-in-class selective inhibitor of nuclear export. Some cancer cells have too much exportin 1. Exportin 1 moves too many anticancer materials from the nucleus to cytoplasm, and hence the anticancer materials cannot work to fight the cancer. Sadly, Naxol inhibits the exportin 1 and hence inhibits the nuclear export of tumor suppressor proteins, resulting in accumulation of tumor suppressor proteins in the nucleus. This leads to oncoprotein reduction, cell cycle arrest, and cancer cells apoptosis. Let's move to bispecific antibodies. Bispecific antibodies represent an innovative precision immunotherapy approach that helps the body's immune system target lymphoma cells and appears very promising. Bispecific antibodies have two aims. One aim of the drug attached to the specific protein on the lymphoma cells, and the other aim activates the immune cells in the patients to kill the lymphoma cells. Bispecific antibodies appear capable of inducing complete response in patients with refractory non-Hodgkin lymphoma, including patients that have failed multiple therapies, hematopoietic stem cell transplantation, or CAR T-cell therapy. Several bispecific antibodies are in development for treatment of non-Hodgkin lymphoma, and some of the drugs are listed in the table. Glofitamab. Glofitamab is a CD20-CD3 bispecific T-cells engaged monoclonal antibody BiTE. In a study of 154 patients with relapsed refractory aggressive B-cells lymphomas, mostly DLBCL, one-third of whom had previously received CAR T-cells therapy, approximately one-half experienced durable responses with glofitamab. Approval is currently pending in both US and Europe, but glofitamab is a treatment option for relapsed refractory DLBCL, including patients previously treated with CAR T-cell therapy. Conclusion. For Hodgkin lymphoma, the cure rate is high. So the goals for advance in treatment of Hodgkin lymphoma include to minimize the long-term consequences from chemotherapy for those who survive from cancer, and to find the novel treatments for those who remain refractory or progressive disease. For non-Hodgkin lymphoma, with modern treatment regimens, overall response rate is good. Although most patients achieve complete response following first-line therapy, key unmet clinical needs remain for those with primary refractory disease or relapse. Management of relapse or refractory DLBCL has changed rapidly in recent years with approval of CAR T-cell therapy and various immunotherapies. CAR T-cell therapy is a paradigm shift for treatment of relapsed refractory B non-Hodgkin lymphoma. Despite recent advances in the treatment of non-Hodgkin lymphoma, some patients still succumb to non-Hodgkin lymphoma, and new treatments are needed. Clinical trials are now largely focused on finding promising novel treatments for aggressive lymphomas which are not cured with initial therapy. This is, these are my references, and thank you.
Thank you, Associate Professor Dr. Winwin, for your excellent talk. So I would like to request our audience, if you have any question, please post your question in the chat box so that Associate Professor Winwin is happy to answer your questions. Doctor, let us wait for 1 minute if there is anything, any questions. Otherwise, we will move.
Okay, thank you,
There's one
Prof.
comment.
Asha.
Okay, if there is no any other further question, thank you so much once again, Associate Professor Dr. Winwind. And we would like to invite the second speaker of today, which is Associate Professor Dr. Myukita. And he is done his MBBS in 1999 from University of Medicine, Yongan, Myanmar, and Master of Medical Sciences and Pediatrics in 2006 from University of Medicine, Yongan, Myanmar. And then after that, Master of Medical Education in 2017 from University of Dundee, UK. Then postgraduate diploma in tertiary teaching in 2018 from UCSI University, Malaysia. And he's also done fellow in of Higher Education Academy, UK, member of Academy of Medical Education, UK, and having a vast experience of 15 years of teaching and as a medical educationalist. At present, Dr. Mukita is serving as associate professor at head of and also head of medical education at Masa University. So with this, I would like to invite Associate Professor Dr. Mukita to give a talk, and floor is yours, Doctor.
Thank you, Dr. Suraj, for your introduction. Good afternoon, everyone. Today, the topic I'm going to discuss is the lecturers as curators. Actually, this is the sharing of my personal experience in teaching medical students, especially for the knowledge sharing with the students. Before we start the presentation, this is the disclaimer for today's presentation. The content of this presentation is for the educational purpose only. The opinions and the views herein are my own, and they do not necessarily represent the stance of the Master University. Any citation made do not imply an endorsement or recommendation either by me or the university. The cover picture is created with Dell E OpenAI, and other pictures are from Canva. There is a big difference how our students learn compared to what we did when we were medical students. So for me, when I was a medical student 30 years ago, the way I learned, the way I study is different from how my students are doing today. In the past, we only needed one main textbook, some lecture notes, and the clinical experience of our lecturers. And we asked our lecturers what to read, where to find them, and sometimes we read what we found, but our lecturers didn't find. So do our students. They ask us what to read and where to find them. The problem is today there is a lot more information available from many different sources, and many of them are free and easily available on the internet. And many students told me that it is overwhelming. In addition, they said that they are not sure whether the information they found is relevant, accurate, and up to date. And more importantly, we cannot read everything on the internet. For example, if you Google the word tuberculosis today, there are 304 million results and will be increasing tomorrow. So when we do not stop our students from searching study materials by themselves, it is our responsibility as the lecturers to make sure that they are exposed to relevant, accurate, and up-to-date information. So what should we do? We have to do content curation. In fact, this is not a new phenomenon. It has been a part of teaching and learning for a long time. Generally speaking, all of us, all lecturers are, and we will be content curators. We were content curators, we are content curators, and we will be content curators all the time. The difference is, in the past, our lecturers would create content from textbooks, journals, and research papers to create course materials. However, the internet has transformed the way we curate and the tools we do so. This is a challenge for us to go through all the stuff on the internet to find what we need and then to know how to incorporate them into the curriculum. No worries, actually, there are many educational content developers who create more engaging materials. We can wisely use their resources. So it will be easier for us if we use the resources someone created. Some people find this will change and this will threaten the skill of the lecturers. And some say using someone's creation is unprofessional. Personally, I feel this is liberating. It allows me to focus on other aspects of facilitating students' learning. I create the contents whenever I create a course material. So even though the roles of the teachers is similar in the past, now, and in the future, the practice has changed and it will be changing. Then content creation has become an increasingly important competency for us in the digital age. So, what is content creation? There are many definitions by different scholars. In general, educational content creation is an art of sorting out a vast amount of educational content, organizing them around a specific educational topic in a coherent way. So there are some keywords. Number one is finding and sorting out educational content, organizing them around a specific educational content in a coherent way. So we need to find, we need to sort out, we need to analyze, we need to organize in a coherent way around a specific topic. That is how we curate. But we need to remember that curation and creation are different. They are two distinct approaches to manage and deliver information to the students. So first, content creation. It involves selecting, evaluating, and organizing existing material from the sources such as books, articles, websites, videos. On the other hand, content creation is developing original material, such as writing a book, producing a video, or designing a course from the scratch. So to put it simply, content creation is like making a furniture from the ground up. Content creation is decorating a room using existing furniture and accessories. So, like making furniture, it requires a significant investment of time and resources. Creating original content can be time-consuming, and it's a demanding process. But by contrast, content creation is more efficient and it's a flexible approach to develop educational materials. And it allows us to draw on a wide range of resources to support learning outcomes. However, I don't mean that curation is better than creation. I don't mean that let's not do content curation. So the question is, shall we do curation or creation? Or shall we do both together? They have their own unique advantages and challenges, and they have their own places in education. We can benefit using both approaches. The best approach is it depends on the learning outcomes and the needs of the students. In some cases, creating original content is needed. In some cases, creation will be more effective approach. So ultimately, the key is to strike a balance between creation and curation, using each approach to support the learning journey in the most effective and efficient way possible. So how do we balance content creation and content curation? Because this balancing is important for the lecturers to effectively support the learning objectives, making most of their time and resources available for fulfilling the learning outcomes of the students. So here are some tips on how to strike a balance between the two. So the first one is make yourself clear with learning outcomes. Before deciding whether to create a new content or curate the existing content, begin by making yourself clear with the learning outcomes. This will help you determine whether the existing content is sufficient for meeting the learning outcomes, or if you need to create new content to fill any gaps. The second is prioritize. Focus on the most important topics and the learning outcomes, and determine which require new content and which can be supported by created content. The thought is mix and match. Consider using a combination of curated and created content to provide a well-rounded learning experience for your students. Use created content as a starting point and supplement it with your own insights and expertise to add value and context. The fourth is collaborate. Work with your colleagues to share and co-create content. Collaboration will help you to distribute the workload and result in higher quality content. So, by striking a balance between creation and curation, we can provide our students with high quality, engaging, and effective learning experiences while making the most of their time and resources. So, this suggestion is we need to balance between the weightage for content creation and content curation because they both are effective. So what are the advantages of content curation? There are many advantages. So the first one is it saves time and effort. One of the primary benefit is this one. It can save our time and effort. By curating existing resources rather than creating new ones, we can focus on the most important aspect of a topic and provide students with wider range of perspectives and formats. This will free up your time for other teaching activities. The second benefit is it enhances learning outcomes. By providing students with high quality and relevant resources, educators can provide students engagement, motivation, and retention. It also encourages critical thinking skills of the students in many ways. First, it can help students develop their information literacy skills by teaching them how to evaluate and select resources based on credibility, relevance, and accuracy. Second, it can provide opportunity for the students to compare and contrast different perspectives from multiple sources. And it encourages students to reflect their own learning and develop a deeper understanding of the topic. The fourth benefit of content creation is it provides personalized learning experiences of the students. By selecting the students' interest, the resources will be in their learning styles. It will help to scaffold based on their previous knowledge. We can tailor the learning experiences of their individual needs. This will motivate students and they will improve their retention of knowledge. The last benefit of content creation is, as I said in the previous one, it promotes engagement and motivation. These are a few examples of advantages of content creation. However, content creation is not without challenges. So I will present some challenges I face when creating content. These are my personal experiences. One of the primary challenges is finding high quality resources that are accurate, up to date, and relevant to the topic. With the abundance of information online, it's quite difficult to go through and identify resources that meets the criteria to accurate, to be up to date, and to be relevant. So it requires and it makes me to have a strong information literacy skills and the ability to critically evaluate sources. So I was regularly updating myself and educating myself to have a strong information literacy skills. The second challenge is to ensure copyright compliance. We need to be very careful to use the resources that are legally and ethically permissible to avoid infringing on copyright laws. This is especially challenging when creating multiple sources, such as videos, images, because the copyright considerations for these materials are very complex. The third challenge is maintaining relevance and accuracy. Because content creation is an ongoing process that requires me to continually update and evaluate resources to make sure that they remain relevant and accurate. This is really time consuming, and it requires me to stay up to date with the latest research and development in my field. Additionally, I must be careful to avoid bias and to ensure that the resources I curate are balanced and representative of a range of perspectives. Students have different learning styles, different needs and preferences, which makes me difficult to create content that appeal to everyone. This is the most challenging for me because it is hard to identify and cater different learning styles and provide resources that are accessible to students with different abilities or disabilities. The last one is I need to warn myself at all times not to overload my students with too many resources and not to fail to prioritize the most important information. It is not to overwhelm the students, not to make it difficult for them to identify the key concepts and takeaways from the material. So whenever I create content for a topic, I need to ensure the balance between providing enough resources to facilitate learning and to avoid overwhelming students with information. So I did some literature search and educate myself how to do content creation. Number one, again, to start with learning outcomes. It is important to identify the learning outcomes for the lesson or the course to ensure that the content selected is relevant and aligned with the learning outcomes. When creating content, it is important to use a variety of resources, including peer-reviewed journals, reputable websites, and multimedia sources to provide students with a range of perspectives and experiences that is not from a single journal or single textbook or from a single website. We should carefully evaluate each resource to ensure that it is accurate, reliable, and up to date. At the same time, we should verify the credibility and the expertise of the author or the creator of the resource. I remind myself to create only authentic, relevant, and high quality content. We should only use resources that are legally and ethically permissible and obtain permission or properly attribute sources when necessary. Content should be organized in a logical and easy to navigate manner, making it easy for the students to find and access the resources they need. In short, keep it simple, comprehensive, and relatable. Provide content and annotations. It is to help the students understand the significance and relevance of the content and also help guide their learning. It means you just don't provide the links to a video or the upload just the journal article. You add context and annotations. And encourage the students to provide feedback on the created content. This will help us improve the process. And most importantly, work with an instructional designer. They work in the background, but their influence is very powerful. They will help you ensure that the content is organized, structured, and presented in the way that promotes effective learning. They will also incorporate instructional strategies like gamification to engage learners and enhance their learning outcomes. Moreover, they will also help you evaluate the effectiveness of the content and make necessary revisions or updates. And they will also use the data and the feedback from the learners to inform your creation decisions and to ensure that the content meets the need of the learners. Finally, continuously review and update the content. In other words, keep it fresh, because creation is an ongoing process, and we should regularly review and update the resources to ensure that they remain relevant, accurate, and up to date. However, please remember that creation is not duplication. The purposes behind these activities are different. So, curation is selecting and organizing existing content in a meaningful and valuable way for a specific audience or purpose. The focus is on filtering and presenting relevant and high quality content in a way that provides context and meaning and add value to the original content. It involves adding your own commentary or interpretation, presenting in a new and unique way that provides additional insight or value to the audience. On the other hand, duplication is simply copying and replicating existing content without adding any additional value or perspective. The focus is to produce the content without any changes, just with the intention of passing it off as an original content. And duplication is often seen as a form of plagiarism or copyright infringement because it involves using someone else's work without their permission or attribution. So, creation involves adding value to the existing content through selection, organization, and interpretation. Duplication involves simply copying existing content without adding any value or perspective. So we will curate, we will not duplicate. So what are the take-home messages? Number one, content creation is a valuable tool to enhance our teaching and to improve our students' learning experience. Creating high-quality content from various sources, we can provide our students with a more comprehensive and diverse set of resources. Number two, this saves time and effort for both our students and ourselves. Number three, there are some challenges to content creation. This can be overcome through careful planning and adherence to ethical guidelines. The benefit of content creation outweigh the potential challenges. So in conclusion, by developing and adopting best practices for content creation, we can effectively create content that supports our students' learning and their learning experiences. So, how to be a lecturer as a curator of internet era? We need to be a specialist in digital educational materials and know how to select, analyze, organize, and recommend the right content to the students at the right time. So these are my references, a very few, because most of the discussions are my opinions and my experiences. Thank you.
Thank you, Associate Professor Dr. Mukita, for wonderful discussion. So I would like to ask the audience if you have any questions to ask Dr. Mukita, please post your comment in your uh, comment box, please. Any question to Dr. Mukita? So if while someone is assuming somebody is typing any question, so meanwhile, I would like to mention whoever joined today's talk, please fill the attendance form which posted in the chat box, and that will includes the CPD points registration. So there is one response from Dr. Nizamuddin saying that thanks for excellent presentation. Okay, Prof. I think there is no other further any questions. So thank you so much for your wonderful presentation, and thanks for all for joining today's CME talk. And keep follow us for the next CME session in the month of April. Thank you. Thanks, and have a
Thank you,
nice
Dr. Suraj, and thank you, my colleagues.
yeah.
Thank
Have a
you.
nice evening. Have a nice weekend. Bye bye.